This talk is, Scott asked me to talk about arrhythmias. And arrhythmias is a huge topic, okay? We can spend the entire day just talking about one of the arrhythmias here. So I'm going to talk about some concepts. So I am sorry to disappoint whoever wanted to hear a state-of-the-art evidence-based medicine lecture. This is not going to be, okay? We're going to just go through some concepts that is going to help you guys to, go through the EKGs and manage these arrhythmias. We're going to talk about the mechanisms of arrhythmias real quick. We're going to talk more about tachyarrhythmias. If we have time, we'll do the bradyarrhythmias. If not, we can do it next week. And then we're going to talk a little bit about management while we go through all this. So the anatomy of the electrical system of the heart, we all know them, but there are a couple of things that I want to point. One is this over here, okay, the fibroskeleton of the heart. That's why we have an AV node, okay? We have the sinus node, and then all the impulses that come from the atria need to go to the AV node. Okay, whenever we have a communication as the AV node, we have a potential for an arrhythmia. We're going to talk about it. But this concept is very important. This is an isolation that we have between the atrial and the ventricle. Another quick thing about physiology. It's important for us to understand there are differences both in how the action potential works, meaning how the cell works in each part of the heart, and the autonomic innervation. For our practical purposes, we're going to remember two things. One thing is that the nodes, sinus node and AV node, they have a different action potential. They're automatic cells, okay? So they don't work with depolarizing with a sodium channel fast as the other ones do to conduct the impulse. They slowly depolarize into the threshold, okay? And that gives them the pacemaker properties. So that difference is important because our management is going to depend on the knowledge of this. And the other thing is that the autonomic system, all the heart has innervation by the sympathetic system. But parasympathetic influence is mainly in the nodes, okay? That's why our beta blockers work on our heart rate, is because we influence in these two structures right here. The rest of the heart is not affected that much by the parasympathetic system. The mechanisms of arrhythmias, and this is for tachycardias. This is mainly for tachycardias. We have three. Enhanced automaticity, okay? One of these cells that is programmed to depolarize slowly start depolarizing faster and takes over the heart. Re-entry is the most common mechanism. We're going to talk about it, okay? And if we understand it, we understand how our therapies work or don't work. And then trigger activity. It's kind of related to enhanced automaticity, and I'm going to tell you about it. So enhanced automaticity, you see the different action potential. It's a different type of cell. It's depolarizing faster than it should be. It takes over the sinus node. Or is the sinus node just working inappropriately? This is what we call trigger activity. And it's related most commonly in clinical practice with prolonged QT. What we see is in a long action potential, you have these small spikes in instability on the membrane. And if those spikes are big enough, they can trigger a PVC, and that can trigger an arrhythmia, okay? They divide into early and late, depending on the side of the action potential where they are. The early ones are the related ones with QT syndromes and medications that will prolong the QT. These ones are more related with calcium overload. It's one of the reasons why digoxin, for example, the increase in intracellular calcium will cause arrhythmias. Okay? And the re-entry mechanism. I want you guys to understand this concept. Re-entry is the cause of supraventricular, ventricular arrhythmias, both, and it's very common. There's a couple of things that are required, okay? One is a barrier, an anatomical barrier. Can be a normal anatomical barrier, like an AV node, can be a scar, okay? Something that divides two pathways. The other important thing is that the two pathways need to be different. One has to have a slow conduction, and the other one is to have fast conduction. And the difference between those two is not only how fast or slow they conduct, is how they recover. For some reason, in nature, what happens is the slow pathways recover fast. They're ready for the next impulse right away. The fast pathways, they take a long time to recover. So they have a prolonged refractory period. So what happens is, in a normal conduction, okay, when you have one of these barriers, the impulse usually takes the fast pathway, okay? So it works normally. The slow pathway tries to go through, but it finds its way already depolarized by the fast pathway. When you have an extra stimulus that comes early, PVC, a PAC, what happens is that impulse comes down, the fast pathway is slow to recover, it's not ready to conduct, it's refractory. So it goes down the slow pathway. Since the conduction down the slow pathway is slow, by the time it reaches the fast pathway is ready to conduct, and it starts a circuit. Okay? That's how reentry works. Okay? And everything that we do to try to stop these arrhythmias is somehow try to change the properties of the slow and the fast pathway, and we'll take care of it. Okay? Any questions about this? This is important. Okay? So two different properties, one extra stimulus, go down the slow pathway. By the time it reaches the fast pathway, that one is ready to conduct and goes up. Okay, that's it. Okay, now we're going to start talking about clinical stuff and things that we need to know. But these concepts are important. I want you guys to understand. So let's talk about supraventricular arrhythmias. Okay, narrow complex tachycardias. Let's classify them by the mechanisms that we just discussed. First one will be enhanced automaticity. We talk about the cells that have automaticity. One is the sinus node. So sinus tachycardia is the classic one. You can be appropriate or inappropriate. The most common one will be appropriate sinus tachycardia. We just need to find the cause. What is causing this cell to be crazy? Atrial tachycardia. The concept of atrial tachycardia, okay, is different of supraventricular tachycardia. When we talk about atrial tachycardia, we talk another focus in the heart that is crazy. Okay? It's like having a sinus node outside the sinus node. Okay? In this case, it's an automatic focus outside the sinus node that is taking over, is going faster. Usually also related with disease states. Somebody that is sick in the hospital, not infrequently will have an atrial tachycardia. If it's one focus, we call it atrial tachycardia. If it's multiple focus, how do we call it? Multifocal atrial tachycardia. Okay, we're very basic. Okay, all these names are trying to confuse, but it's the same thing. So if we have multiple focus firing at the same time, we call it multifocus atrial tachycardia. Again, related to systemic disease. If this is going on, look for something that is triggering this. Junctional tachycardia will be the AV node, okay, triggering faster for some reason. Reentries, the interesting ones. So multiple. One of the common ones is flutter. We have typical and atypical flutters. We're going to talk about it. And this is a macro reentry tachycardia within the atrium. It doesn't use the AV node. It doesn't use the ventricle. It's a macro reentry circuit in the atrium. AVNRT is a smaller circuit within the AV node. We have AVRT that is a bigger circuit that uses an accessory pathway and a normal pathway, okay, that is interrupting that isolation from the fibroskeleton of the heart. Okay, so the impulse goes down the AV node, okay, it comes off the pathway, and that's the circuit. It can be far away or it can be very close to the AV node. It can be anywhere in the fibroskeleton. Okay? Another way to classify it, okay, this is more clinical. This is what is going to make you take the decisions of what to do with these patients. The narrow complex can be regular and irregular. The easy ones are the irregular ones. Okay? Can somebody tell me two irregular narrow complex tachycardia? Quick. Atrial fibrillation and another one? MAT. Very good. So atrial fibrillation, flutter could be, flutter is usually regular, but if you have intermittent conduction, it can look irregular in an EKG. PACs, okay? And multifocal atrial tachycardia is basically many PACs, okay? And they look irregular. Each focus is firing at a different time, they look irregular. Their management is a little bit different. You're going to look for a cause, you're going to look why this patient is doing this, and you're going to try to control the rate. The regular tachycardias, okay? You have sinus tachycardia, autonomic focus. You have an atrial tachycardia, an autonomous focus. You can have flutters. It's very typical to have flutters. Can be typical and atypical, and what we call the SVTs. And when we call about SVTs, we're talking about AVNRT, AV node reentry tachycardia, or AV reentry tachycardia. That's related to accessory pattern. So, the regular ones, sinus tachycardia versus atrial tachycardia. So sinus tachycardia, sinus node triggering. Look for the cause. There is such a thing called sinus node reentry tachycardia. Might be why somebody have inappropriate sinus tachycardia. It's just a fast rhythm with a SSA morphology. You can have a focal atrial tachycardia by an autonomic focus, and you can have a micro reentry circuit. Atrial tachycardias are not that easy. It's not only autonomic focus. Sometimes can be a micro reentry circuit. It's incessant. It's causing problems all the time, and that needs to be fixed. That needs to be burned. So how to differentiate them? You use the P wave. Okay? You look for the P wave. How is the normal P wave on a normal sinus rhythm? Okay? If you look at it, it's coming from the top. It's going to depolarize all the atrium on the way down in the same direction as lead 2. Okay? It goes to the direction of lead 2. And it's going to be bigger in V1 because V1, the electrode, is going to be lying just in front of the atrium, so it's going to be bigger there. So, in this case, this EKG, tachycardia or atrial tachycardia. And it's just to prove a concept. And look at the P wave. Look at the axis and the morphology. And we said we are going to look at lead 2 and we're going to look at V1. Okay? V1 is positive, looks fine. But in V2, I will expect to see a positive P wave in lead 2 and no P wave. And this guy is on tachycardia. This is a classic example of atrial tachycardia. Okay? This can be an autonomic focus or can be a micro reentry.
We don't know what is a focal area of the atrial trigger. This is easy if the focus is away from the sinus node. Okay, if it's down in the atrium, if it's in the left atrium, it's easy because your P wave is going to be very different. If the focus is very close to the sinus node, it's going to look similar to the sinus tachycardia, and it's going to be more difficult. Another trick is just use an old EKG. Get an old EKG, see the P wave, see if you see any difference in the P wave when the patient is in normal sinus rhythm and the current tachycardia. If it's really different, you have a diagnosis. Sinus tachycardia sometimes looks very pretty, sometimes doesn't look that pretty, okay? But the axis will be normal. If it's very fast, it will be blurred, the P wave will be blurred with the T wave, okay? Don't be fooled, okay? And use your vagal maneuvers also to make a differentiation. A taker, who wants to do cardiology? Let's see if I see any. Look at there, back there eating something that I don't know what it is. What is this? Tachy. You can see. Somebody that is close. Do you see why you need to sit that down? Somebody else.
So it's irregular.
Is irregular?
Yes,
Very good. Very good. This is a classic example of multifocal atrial tachycardia. So if you see from the distance, probably looks like AFib, okay? But if you look closer in AFib, you should not have regular atrial activity. And this atrial activity, each P wave is a completely different morphology, okay? Multiple focus from different sides triggering at the same time, okay? This is multifocal atrial tachycardia. Here you can see it a little bit better. By definition, by textbook, you have to have at least 3 morphologies, okay? If you want to think about it another different way, they're all PACs. They're all PACs. The rhythm is basically PACs. What is triggering this? Usually lung problems. If somebody has this, think about the lung. Somebody is making the right atrium very angry. Okay, the pressures are acutely increased, the wall is stretched, and the patient is having all this. Okay, look for the cause. Atrial flutter, reentries, another regular rhythm. We have two big classifications, typical and atypical. Okay. And the other way we can classify it is isthmus dependent or not isthmus dependent. And you guys are going to hear that again and again. I'm going to tell you what is that. Typical flutter, what it is a micro reentry circuit that is around the right atrium going incessant. And the circuit that it used involves the isthmus that is between the tricuspid valve that will be here in front, okay, and the inferior vena cava, this piece of tissue right there, okay? Okay, and it goes up the atrium and down and needs this piece of tissue to work. Okay, that's what we target when we do an ablation of this tachycardia. The typical one, the textbook one, is the counterclockwise. It goes in this direction. You have clockwise atrial flutter. Okay, it's also almost isthmus dependent. It will respond to the same therapies, but it's just going in the opposite direction. Okay, and the EKG, the positivity or negativity of the P waves are going to be completely opposite of the counterclockwise. Then you have the true atypical flutter, okay? It's usually a left-sided circuit,
okay? Something that really doesn't look the morphology to a typical EKG. We're going to look at it. And you can have any scar-mediated flutter. If you have a scar in the heart, people usually with private heart surgeries or all MACE procedures, they can have a re-entry circuit at what any scar that is in the heart. So how do they look? The classic typical flutter is the one that is going to have in V1, remember V1 and lead 2 are the ones that we're going to use to see the P wave. In lead 1 it has positive P waves, but the characteristic, okay, sawtooth pattern is going to be in the inferior leads, 2, 3, AVF, and it's going to be negative, okay? And it never rests. You never have an isoelectric line. It's always fluttering, okay? And the sawtooth pattern, the characteristic is that it goes down slowly, up fast, down slowly, up fast, down slowly, up fast. That's the classical one. If it's reverse flutter, it's just going to be the opposite, negative in V1 and positive in the inferior leads, okay? So that's when you see somebody and you say, hey, I think I have somebody with a flutter, and somebody grabs the EKG and says, oh, this is typical flutter, oh, this is a typical flutter, oh, this is isthmus dependent, oh, this is isthmus dependent. And the treatment that a cardiologist is going to give depends on that. You know what they're talking about, okay? It's very easy. It's all related to this. This is the most common way to see it, okay? When you have, this is 4-to-1 alternated with 3-to-1 block, okay? Every 4 and every 3 flutter waves, it conducts 1 to the ventricle. You can have it fast, 2-to-1. When you have it 2-to-1, is that you get confused. Is this just SVT? Is this a flutter? I don't know. I'm not sure. Okay? But then again, this is a perfect example. Okay? The EKGs real life are not necessarily like this. But you can see that there's no isoelectric line. Okay? That you have this sawtooth pattern. Okay? Very classic. Negative in the inferior lead, positive in V1. Okay? So the other thing is the rate. Flutter waves are usually 300 beats per minute. Okay? And if it's conducting 2-to-1, it's going to conduct at 100 beats per minute, plus minus a little bit. Okay? But if you have something that is at 150, 140 beats per minute, and it looks like this, and you don't have an isoelectric line, it might be flutter. Another thing about this re-entry of arrhythmias, every time you go into a patient's room and you look at the monitor, and the monitor is fixed in the same height rate, it's 172, and it's 172 all the time, and it doesn't change, and the patient is breathing, and the patient is moving, and the rhythm is 172. That is not sinus. That is a re-entry circuit, okay? Can be any of them. But just by saying that, if the nurse calls you to the bedside, hey, I have this patient with tachycardia, and you know the patient is febrile and have many reasons to have sinus tachycardia, but the heart rate is fixed and not moving with respiration or anything, that's a re-entry circuit, that's abnormal, okay? Be suspicious. Another example of flutter, 2-to-1 flutter, in this case, okay, with a right bundle, so it looks a little bit weird. But again, don't be fooled. Okay, look at your classic morphology, and if you have the doubt, you're going to do anything you can do to slow this down. You're going to do a vagal maneuver, or you're going to give him adenosine or something. We're going to talk about it. So the treatment that I was talking about is ablation. Flutter is the most easy tachycardia that can be ablated. It's fixable. The procedure takes 40 minutes, 45 minutes. The complication rate is less than 0.1%, and the successful rate is greater than 90%. So if the circuit is right there, okay, around that, okay, isthmus between the inferior vena cava and the tricuspid valve, what we do is we put a catheter there and we burn that. And just doing a line there will take care of the circuit, and that is fixed. That's why you'll hear the cardiologists, every time you have a typical flutter, pushing for an ablation. And it's not that you just want to do a procedure, it's that they can fix that problem. And usually this can trigger atrial fibrillation and remodeling of the atria. So always think in typical flutter that you can fix it, you can send it to somebody that can do that burn. Atrial fibrillation, they put them together. They usually lump AFib, aflutter. They're completely different animals. We saw that one is a macro re-entry circuit around the atrium, okay? And this is complex. This is thought to be some automaticity issues in the pulmonary veins, and then some circuits within the atrium that, you know, promotes the continuity of this. This is a different animal. We don't understand it very well. It looks very different, okay? This is a classic AFib, okay? When you see it like this, it's easy. When you see it faster, it can be more complicated, or when you see a gross AFib, okay? That can be confused with flutter. This looks like flutter, but if you see the flutter waves, Okay, what it seems to be flutter waves are not the same size, are not the same speed. Okay, and if you think about a reentry circuit, you need to have the same thing again and again, and this is clearly not it. This is coarsely thick. When it goes fast, it's hard to tell if it's regular or irregular. If this guy is running at 200 beats per minute, it's very difficult to tell. Grab your strip, you can trace it down, okay? Use your calipers, use like a piece of paper, okay? If you really notice it is irregular, it doesn't look like classic AFib, but it's irregular, and that gives you a good hint. Let's put the clinical concept together. Here, I don't know what is supposed to be here. Okay. Patients with new AFib, look for the cause. Something is making that atria, okay, angry, and it's not ischemia. Ischemia doesn't cause atrial fibrillation, okay? Don't think about ischemia when you see a new one. So, patient with atrial fibrillation, look everything else. Be a good internal medicine doctor. Don't send it for a stress test, okay? That's the last thing that you're going to do, unless they have chest pain and classic signs. AFib with RVR, look for the cause. Think about it as a sinus tachycardia, okay? And more if a patient has chronic AFib. If somebody has chronic AFib and they have known AFib for many years and they're on Coumadin, and today they are meeting with AFib with RVR, it's not just because the AFib decided to be fast, okay? That sympathetic system is working, okay? And the conduction is better. And somebody is making angry the AV node. So look for the cause, okay? Don't just throw metoprolol on them. Remember anticoagulation, if not contraindicated, okay? It's a caveat in this, AFib and flutter. Rate control versus rhythm control, we're going to talk about it. This confuses people. And you're going to get called in the floor because you don't know, the nurse doesn't know if the patient is having very frequent PVCs or the patient is having short runs of ventricular tachycardia. This is the Ashman phenomenon. The AV node is a very special structure, okay? And it's designed to slow down the conduction of what comes from the atria to allow the atrial empty before the ventricular contraction. One of the properties is when the impulses come fast, okay? The recovery is fast, okay? Down the conduction system in the bundles. When the conduction is slow, when the impulses are slow, for some reason the recovery also is slow. So the Ashman phenomenon, what it happens is when you have a rhythm, and then you have a prolonged RR interval, okay? You have a cycle that was a little bit longer, okay? And then you bring an early one right after that. Because of this prolonged, okay, RR interval, the recovery is going to be prolonged. You get the extra impulse in a partial refractory period of the bundle, and you carry aberrancy. So it's conducting down, probably the right bundle was partially refractory, it's not conducting, and you have a right bundle morphology, okay? And it's very frequent in AFib, very frequent. And a lot of people call, oh, this guy have AFib with frequent PVCs. No, if you see, it's always associated with a slower interval before, okay? Always related with a lower interval. Can be alone, can look like bigeminy, can look like doublets or triplets. Just be aware of this, okay? And be a physician. If you think this guy is having VTAC, okay? Treat it as such, but be aware of this. Atrial fibrillation, when you send it for a definitive fix, like an ablation, is a different animal. This is usually comes from the left side. You need to burn around the pulmonary veins, isolate it, then make some lines to knock down these these circuits, okay? Reentry circuits are in the atrium. A lot of sympathetic. This is a 6-hour procedure. Complications are higher because you need to puncture the interatrial septum, and it's about 60–70% efficacy. So it's not perfect. Usually they need to go to a second procedure. So that's why you'll see, okay, FIB, or the patient have flutter but also have FIB. Let's treat it with medications. It's just flutter. This probably is going to be fixed with an ablation, okay? It's just a reentry. Supraventricular tachycardias, okay? This is the toughy one. So we call supraventricular tachycardias whatever we don't know what it is. We suspect it's an AVNRT or AVRT, a reentry circuit. Can be an atrial tachycardia that's just going fast, is narrow, fast, regular, okay? It's difficult to differentiate. And also a typical flutters look similar, okay? So when we call about SVT, we're talking about something that's narrow, regular, incessant, and we don't know what it is. Okay, it's probably one of these. All these look the same, and we're going to try to identify it. AVNRT. The reentry circuit AVNRT is within the AV node. Okay, it uses this low pathway and the fast pathway. How is that? The AV node is not just a compact circle. It's not an olive there in the heart. Okay, it has pathways that fits, okay, the dense part of the node. Everybody have a fast pathway. Okay, fast conducting. Everything that's come from the atrium needs to go through the fast pathway and goes to the node. A lot of us, a great percentage of normal population have a slow pathway. Okay, slow pathway usually is inhibited by the fast pathway. Okay, it's depolarized first, and this is knocked down. So what happens is that reentry circuit that we talk about happens between these two pathways. So the impulse goes down. Okay, usually goes to the fast pathway. Fine. If you have an extra stimulus, it's going to go down the fast pathway. The slow pathway, the fast pathway is already ready to conduct, goes up and triggers the arrhythmia. Okay? Now you look at it. When you go down, okay, and you reach the His bundle and the fast pathway, this conduction down and up is very fast. It's normal conduction system. So the atrium and the ventricle are going to be depolarized at the same time, pretty much at the same time. And that's going to help us differentiate. AVNRT, regular, okay, narrow complex, and if you look for a P wave, it's very difficult. When you look for a P wave here, it's a retrograde P wave that is happening almost at the same time as the QRS, and it's this negative thing that is after the QRS. It looks like a S, we call it pseudo S wave, or these very tiny positive things here after the QRS. That's the P wave here. That's retrograde P wave. If it's low enough, you can see it. Okay, that makes a diagnosis. This is another example. Okay, looks very similar here. Have atrial enlargement, so you can really see this negative P wave here. Okay, that's what we're looking for. We're going to talk a bit about how to classify these supraventricular tachycardias. AVRT, a little bit different, but also a reentry. Okay, remember the first example that I put the accessory pathway out here. Okay, it looked like a big circuit. The circuit can be very small. Okay, you can have the reentry circuit right there. Okay, it's usually triggered by a PVC. Same concept. To make it a little bit more interesting, okay, this circuit can be what we call orthodromic. Orthodromic just meaning goes through the natural pathway. The natural pathway is the AV node, His bundle, Purkinje fibers, and the same and the conduction system. And it goes up the accessory pathway to the atrium and down again. This causes a narrow complex tachycardia. Okay, one of the things that can happen is that the PAC triggers conduction through the accessory pathway first. It goes through the myocardium, then it feeds the conduction system and goes up. If that's the case, we call it antidromic, not natural, and it will cause a wide complex. Wide complex because there is conduction through the muscle that is not designed to conduct, and it's going to be just slow. Okay? Just a concept. This is rare. This is very common. So this is AVRT. Huh? We're going to talk about the RP. Good question. Okay, hold it, don't take my thunder. We're going to talk about it. This is a classic example of AVRT. Looks like AVNRT. If you look at it, looks similar. It's difficult to differentiate. That's why we clump them together. Okay, clinically, not electrically. Okay, and here you don't see that P wave, but we're going to talk about it. This is a classic example. This is an antidromic. Wide complex, regular, rare. Whenever you see something like this, think it's VTAC, don't think it's this. Okay? But it's going to be in our differential. P is the key. In EP, we love the P. We talk about the PP interval and all this stuff. And for the arrhythmias, you need to focus on the P wave. And what you were talking about is the RP interval. The RP interval is the distance between the R wave of the QRS complex and the P wave. Okay, it's basically telling us how is the relationship between the ventricular activation and the atrial activation. Okay, and it's classified between the short RP and long RP. Do you have a short RP or a long RP? No, never mind. In relation with the RR interval, the short RP tachycardias. Short RP meaning is less than half the distance between an R and R. Okay? So if it's here early, it's going to be short. It's here beyond, it's going to be longer. So the short RP tachycardias, okay, we're going to see them whenever we have retrograde P waves, okay, meaning the ventricle is activating and then the atrium is activating, okay, as we saw in AV-NRT, and AV-RT is the same thing, okay. What happens is the impulse goes down this slow pathway, reaches the ventricle, and immediately goes up to the atrium, okay, and you see a R wave right there. That's a short RP, classic short RP. Same thing can happen with AV-RT, okay. So the AV-NRT is very short. It looks like this, okay? And the AV-RT usually is not within the node. It has to travel a little bit of distance to reach that accessory pathway. And it's also short. It's less than half, okay? But it's not just attached to the QRS. You see the difference? Okay? So then you have atypical things and concoction. For example, you have an atrial tachycardia with a slow AV conduction, okay? Meaning like a type 1 AV block. You're going to have a P wave, a lot of times it's going to happen, and then you have your QRS. But that's not the classic. AV-NRT, again, short RP, this is very classic. And sometimes it's very subtle, very small changes. And the way to diagnose this, a lot of times, we ask for the old EKG. We ask for the old EKG to see if that bump was there before. If it's not, we have a diagnosis. The same in lead 2. If we have a negative deflection, what it looks like a small S wave, we look at the normal sinus EKG. If it was not there, it's probably AV-NRT. Long RP tachycardias, the classic one is atrial tachycardia. Okay, it's a normal conduction, so the P wave is going to be just before the QRS. The P wave is activating that QRS. So the classic one will be atrial tachycardia. And to make it interesting, you guys don't need to remember this, but I think it's cool. Is if you have what we call a typical AV-NRT, instead of going down this slow pathway and then activating, okay, the atrial through the fast pathway, this is the other way around. It goes down the fast pathway, activates the ventricle, and then slowly goes to the atrium and activates the atrium. That gives more time, okay, between the R wave and the P wave. So this is the RP. Whenever we see a supraventricular tachycardia, okay, and you call somebody for help, they're going to try to find out if this is a short RP and long RP tachycardia. And basically what we're trying to figure out is an AV-NRT or AV-RT versus an atrial tachycardia, or something like sinus tachycardia inappropriate or so. Those are the big differentiations. It's not perfect, but that's the way to differentiate atrial tachycardia versus AV-NRT or AV-RT. Any takers on this EKG? It's a simple one. Simple one that you can send for ablation and it will be fixable 80% of the time or more. Oh, sorry. So we're going to, it's a tachycardia, it's narrow, okay? It's fairly regular, doesn't look like a fib. So you see V1 and inferior leads, you look for the P wave. Huh? What did you say? Yeah, it's a flutter, okay? It's a flutter. You see in the inferior leads you see, okay, the negative deflections. I told you guys, it's not always perfect. It's not always like the example I took from the book, okay? You see the negative deflections. You don't see a clear isoelectric line. It's always activation of the atrium. And you see the positive, okay, flutter wave here in V1. You see that? Okay? So be subtle, okay? If you know what you're looking for, if you're looking for the P wave, you're going to find them, okay? And it's not going to be always the perfect example. So white QRS. Let's talk a little bit about the white QRS tachycardia. In an EKG, this is time. So white means it's taking longer for depolarize, okay? So it's not going through the normal conduction system. The normal conduction system is a highway for electricity that will depolarize the entire myocardium at the same time, okay? This is not going through the highway, and the myocardium is slowly depolarizing until the entire heart is depolarized. So that's why it looks white. Don't be afraid of white. White is just taking longer to depolarize. So whenever you see a white QRS, don't be afraid. It's just an abnormal conduction. We're going to figure out why. Okay? It's either something originating in the ventricle, okay, that is, of course, not going through the conduction system, or something that is originating above, but is conducting abnormally down. A narrow, okay, same thing, same activity, but conducting different. So this is the big question, VT versus SVT with a better conduction. White is QRS greater than 120. The myocardial depolarization is not through the normal conduction system, okay? And how to differentiate these two. This is number one. Is VT until proven otherwise, okay, in the right clinical context. 80% of all takers is VT, only 20% is supraventricular tachycardia. VTs, we classify them in monomorphic, polymorphic, orthosats, and ventricular fibrillation. Okay, it's different animal. We treat them similar. And the SVT was aberrant sequence can be a patient with a bundle branch block. They had a left bundle branch block to begin with, and if they have sinus tachycardia, it's going to look wide because they are going to have a left bundle branch block. Rate dependent on functional bundle branch block. Sometimes the conduction system is not that healthy, and if you demand a lot from the right bundle, okay, it's going to block. It's going to give away, okay, and you're going to have a right bundle. This is the most common functional aberrancy. These two have a typical bundle morphology, okay, and it will be looking like a classic textbook bundle morphology. Accessory pathway, last we saw the antidromic. Instead of conducting through the conduction system, you go through the myocardium and it looks wide. A pace rhythm, okay, and a lot of, we're pacing for the ventricle, so it's like having an ectopic focus in the ventricle. The problem is that in our telemetry systems, you actually need to tell the telemetry system that your patient have a pacemaker. The tech needs to do it. If they don't put it in, you can have one of two things. One, a super huge spike, or you don't see anything, depending on the device, okay? So if you see a wide rhythm, a wide complex, okay, just make sure that you're not dealing with a pacemaker. Have it in your differential. And drugs on metabolic. Classic example, somebody that comes with a potassium of 8, okay? A concept that I wanted for you guys to have clear is this concept of pre-excitation. The WPW is an accessory pathway. It's the same accessory pathway that causes AVRT. We call it WPW when we see pre-excitation in the EKG. What is pre-excitation? Pre-excitation is the myocardium is being excited before it should be depolarized through the conduction system. So what happens is this impulse that comes from the atrium, a sinus beat, okay, goes through the AV node and down the conduction system, but also competes and goes through the accessory pathway. And part of the myocardium is being depolarized, is already depolarized by the time the normal impulse arrives, okay? It can be a little bit or it can be quite a bit. The more pre-excitation we have, the more evident it looks in the EKG. And that's the classic delta wave, okay? The normal EKG, forget about the gray zone. The normal EKG, okay, you have the P wave, AV node delay, and the high wave kicks in, okay? In top of the high wave, you have these that as soon as the P wave, the impulse, travels around the atria, it reaches the accessory pathway and depolarizes the myocardium. And that's the delta wave, okay? That's why it looks with a short PR interval, is because it doesn't have a delay, it doesn't have an AV node, it goes straight to the myocardium, okay? So this is just here for the concept. Whenever you hear pre-excitation, it's just that, it's a delta wave, okay? And we think there's an accessory pathway, okay? The mechanism for the arrhythmia is exactly the same what we saw is AVRT. Clues for SVT versus VT, clinical clues. If you have a structural disease heart, that's VTAC. The patient has a history of MI, non-ischemic cardiomyopathy, whatever in the heart, valvular disease, that's VTAC until proven otherwise. If the tachycardia, the patient has tachycardia since childhood or have pre-excitation in the EKG, clearly we know about it, we can suspect supraventricular tachycardia. If you see AV desynchrony, physical examinations, signs of AV desynchrony, canyon A waves, okay, variable S1s, that's VT until proven otherwise, okay? Canyon A waves is basically your atrium is contracting against a closed valve. Termination with adenosine or valsalva maneuver, most likely SVT, not 100%, okay, but somehow reassured. And you look at the EKG in sinus rhythm. If your morphology looks like the same right bundle branch block that this old lady had before coming to the hospital, and now she's just fast with the same morphology, that's probably a supraventricular tachycardia. Hemodynamic stability doesn't make a difference. VTACs can be very well tolerated, okay? So if the patient is talking to you with a heart rate of 130, that doesn't mean it's not VTAC. And it can be irregular, so don't be fooled about that. EKG things, we're going to go quick, again, To memorize this, and you need to see it, and you need to read it, and the idea is not for you guys to remember the criteria, it's for to understand the concepts. When you read it again, to say, oh yes, this is because this, yes, I remember now. AV dissociation, future capture beats, axis, northwest axis, QRS duration, very broad QRSs, atypical patterns of abdominal branch, QRX concordance. Concordance means in the precordials from V1 to V6, all of them are positive or all of them are negative. Positive concordance or negative concordance. Absence of RS pattern in precordial leads is exactly the same, it's concordance. And presence of different bundle branch block from baseline. The patient had a bundle branch block, but now it's a different morphology, okay? That's important. So the examples of each one. AV dissociation. AV dissociation is basically being able to see P-wave on all these disasters, okay? And here they're marked. You see that P-wave, okay? You see that their P-wave, this T-wave is abnormal because the P-wave is lying on top of it, okay? That's AV dissociation. The problem is sometimes you can have VA conduction, retrograde conduction, intermittently and can fool you. But if you see this, this is very likely to be VTAC. Unfortunately, only about 30% of cases we are able to see this in an EKG. But if you look for it and you see it, you have a diagnosis. Fusional capture beats. Basically, you're depolarizing the heart from the ventricle up, okay? And suddenly, one of the sinus beats was able to pass across the AV node before that impulse from the ventricle happened, okay? And you have a fuse, okay, like a pre-excitation type of thing of the impulse that is depolarizing from the normal conduction and from the ventricle. So it doesn't look like a normal sinus beat, and it doesn't look like a VTAC beat, okay? It looks fusion. It's a mixture. It's an in-between. It's a baby of the two. And a capture beat is just a sinus node, a sinus beat that was able to go through before the ventricle depolarized it, and you have a normal conduction beat, okay? So if you see white, boom, and suddenly an arrow one, that's a capture beat, you have VTAC, okay? Most likely. The other one is northwest axis. Everything that's coming to the axis, to my right shoulder, cannot be normal, okay? The sinus node is depolarizing from top to bottom, okay? The only thing I can have something that is depolarizing in this direction is coming from somewhere in the apical, okay, portion of the RV or the LV. So if that energy is coming to my shoulder, okay, northwest axis, it's more likely VTAC. Easy way to catch it, positive R wave, okay? I have an electrode in my right shoulder. If that electrode is positive, the energy coming through it, it's a northwest axis. That's most likely going to VTAC. So if you see a white complex and a positive R wave, you pretty much have your diagnosis. A typical bundle branch morphology, I'm not going to go into details. I'm going to confuse you guys. But it's basically not seeing a regular pattern. These are the things that can be abnormal. For example, if you have a right bundle, if the R is greater than the R prime, okay, that's abnormal. Very wide, single, positive deflection. S-wave, all those things are variations. And a typical left bundle morphologies, again, if the initial part is very wide, if you have any notching in the downsphere, don't memorize this, okay? It gets confusing, and when you have somebody with a fast rhythm, you're not really trying to memorize if they have a notch or doesn't have a notch. But it's there are criteria, okay? Look for them. And all this is meaning that it's really aberrant the site where the depolarization is coming from. Concordance in precordial leads, okay? This is positive concordance. All the precordial leads are positive, okay? That's not normal. That's VTAC until proven otherwise. You can have negative concordance, all of them negative. That's not normal, okay? What is the difference? One sometimes is positive, one sometimes is negative. It's just basically where the rhythm is coming from. If the rhythm is coming from the base of the ventricle, okay, close to the atria, remember that the heart is not lying down. The heart is lying kind of to the front, okay? And my precordials are close to the apex of the heart. If they see something coming towards them, it's going to be positive. That's coming from the base of the heart. If it's all negative, it's coming from the apex of the heart moving backwards. Okay, that's why sometimes it's positive, it's negative. I want to talk about a little bit about how this works when we talk about EKGs next week. There are criteria. There are two algorithms. They're there. You don't need to memorize them. But they're based on what we just talked on, the principles we talked about. The Brugada criteria, absence of an RS complex in all precordial leads. This is concordance. If you have concordance, it's V tach to put otherwise. That's what he's telling. R to S interval greater than 100 milliseconds, meaning the initial part of the QRS, okay, is very broad. It's very slow conduction from the myocardium. That's very suggestive. Atrioventricular dissociation, okay? So we have P wave or we have fusion beats, okay, or capture beats. And morphology criteria for V tach present. This is the things that we talk about. There's another algorithm. The new algorithm is based on AVR. This is what you need to remember. If you have a positive deflection in the AVR, that should not be there, should always be negative because the energy is moving away. That's V tach contributing otherwise. Okay? So you don't need to memorize them. Understand the concepts and look for them if you need them. So it is V tach or SVT? Okay, who said V tach? Why? Positive IVR, okay? And another, you see how simple it was? Just look at IVR, it's V tach. Other things that you can see, this is not a normal right bundle pattern. Okay, a right bundle would have a small r and the r prime is a little bit bigger. That's abnormal, that's not normal, okay? So easy, you see? Get the diagnosis like this. VT or SVT? This one AVR is negative, so that doesn't work. So, did you say V tach again? It's like you're the only one talking here today, man. So why V tach? Positive concordance. Very good. Okay, positive concordance. You see that? All of them positive. You don't need to waste a bunch of time trying to scratch your head if the bundle morphology is typical or atypical, or if there maybe is there a P wave somewhere there. Okay? SVT or V tach? And this is a tricky one. Okay? This is a tricky one because IVR for some reason here is very positive. Or forget about this. Put this, not to confuse you guys. Yeah. This is made from us. This is one of my EKGs. I apologize. This is an SVT. This is a flutter, 2-to-1 flutter with a very broad QRS right bundle morphology. Okay? And here you can see this negative deflection here, okay? This is the T wave and doesn't end in an isolectular, and that's the flutter waves. Okay? And this is positive here. The other positive, this, see this notch here? This is flutter wave, flutter wave, flutter wave, flutter wave. Sometimes it's not that easy to recognize. Okay? But we made the diagnosis of this guy because he coughed. And when he coughed, he started conducting instead of 2-to-1, he conducted 3-to-1 for a while. And we made diagnosis. Okay? Well, again, if you want to slow them down, do a carotid sinus massage. Ask them to push. Okay? Or use your drugs. We're going to talk about the drugs. This is a good one. Who wants to take this? And this is classic. This is pattern recognition, okay? This is pattern recognition. It's regular or irregular? It's clearly irregular, okay? It's clearly irregular. And it looks very broad, very wide. How about if I tell you this is a young guy, okay? And he was told that he had an abnormal EKG since he was a child. Yes, this is an AFib with a guy in WPW. And this is another classical example. And this is more pattern recognition. It really looks like this, okay? So just to throw something different, okay? This guy is sick. This guy is running a marathon. This heart rate is greater than 200. He's not feeling well. You're not going to, okay? You're going to treat this. But you need to be aware that this exists, okay? Because now you know how WPW or AVRT works. So what is happening here, what is brought is because AFib, that is a crazy rhythm in the atria, is now conducting through the accessory pathway, is skipping the AV node, okay? Not all the time, because atrial fibrillation is, what is the heart rate of atrial fibrillation? If that flutter is about 300, how was atrial fibrillation? It's more, 600, so it's crazy, okay? So some of them are conducted through the accessory pathway, some of them are conducted through the AV node. If we give this guy a calcium channel blocker or a beta blocker, We're going to block the AV node, okay? And everything now is going to go through the accessory pathway. This is what happens. This is what happens when a WPW, you give a calcium channel blocker or a beta blocker in the setting of AV. It goes fast, crazy, and this degenerates on ventricular fibrillation. Okay, how are we doing with time? We're doing fine. Can we have 10 minutes more, 15 minutes more? Somebody else talking?
Yes, we're going to
10 more minutes? Okay, just briefly. The management. Okay, it's important for you guys how to know how to initial management. I think the ACLS guidelines are very clear and very useful, and the details you can get them later. So first say hi to your patient. And you say hi to a patient with a tachycardia, you put them in a bed, you put them oxygen, you put a monitor in, you put an IV line, and you order a 12-lead EKG. Okay? I have a patient with tachycardia. Well, you go see them. Okay? You want an EKG, a 12-lead EKG. You want the patient on oxygen. You want an IV line that is working very well. You want the patient monitored and somebody at the bedside. Okay? That's how you say hi to one of these tachycardias. Then, identify underlying cause. Persistent tachyarrhythmia. Okay? Is stable or unstable? Okay? If it's unstable, you're going to shock them. If it's unstable, then you're going to think about it. Okay? And you're going to try to make your diagnosis. What is the difference between you running the ACLS protocol and the nurse that did exactly the same course and the same training on ACLS? Because you understand this. You understand where your drugs are working, what are you doing, and you can do variations depending on your need. So why I put this again? We talked about the difference in the tissues. Okay? If I'm going to give calcium channel blocker or beta blocker, where is that going to act and how it's going to act? This is being depolarized because of calcium channels. My sinus node and my AV node work because they have calcium channels. If I give a calcium channel blocker, I'm going to decrease the conduction through them. I'm going to make things better if that's the pathophysiology. The other thing that we can give, adenosine. Where does adenosine act? What does adenosine do? Anybody? Blocks the AV node. Okay? Final details you don't need to know. It blocks the AV node. When you're doing a push of adenosine, you're blocking the AV node. Okay? For a few seconds, you completely inhibit the AV node. Okay? And it's beautiful because it's metabolizing the red blood cells, it's metabolizing the endothelium, it's going to wear off quickly. Okay? I'm not going to kill the patient of complete AV block, but I'm causing a complete AV block briefly. Okay? And that's how it's going to work. So anything that is using this circuit through the AV node, AVNRT is within the AV node. AVRT is going down the AV node and up the accessory pathway. If I block my AV node, it's going to break the cycle. Okay? It's going to break the tachycardia. That's how it works. Okay? Same thing, sometimes we give those calcium channel blockers that conduction gets slow. One of the cycles is blocked, so it's the resolution of the tachycardia. That's what we're doing. Okay? The third thing, we use beta blockers. And we said that the beta blockers, the sinus node and AV node, mainly the AV node, is highly innervated by the parasympathetic system. So when I give my beta blockers, what I'm doing, okay, is taking away the opposition of the parasympathetic system. Okay, it's going to slow down the conduction. It's going to be the same thing that giving a calcium channel blocker. Okay, so you guys need to understand this. This is what we're doing in clinical practice. Okay, and why things work. So narrow tachycardia management. If unstable, you shock them. Okay? What is unstable? What is the definition of stable? It's not the textbook of lightheadedness and stupor. It's somebody that you walk into the room and you think they're going to die. Okay? And you want to call a code because you're afraid that this guy is going to die on you. That's the one you're going to shock. Okay? That's the one you're going to shock. If they're stable, you want to see if it's regular or irregular. If it's regular, okay? If you have clear flutter or atrial tachycardia, you know the diagnosis, you want to do rate control or rhythm control depending on what you decide. But if you choose rate control, that's fine. You have to diagnose it. You don't need to do anything else other than treat it. If you don't know, looking up to date, and that's it. If you're not clear and you're dealing with what you call a supraventricular tachycardia, do two things. First, be elegant and do a vagal maneuver. Okay? Vagal maneuvers. We talk about carotid sign massage, pushing. Any other vagal maneuvers that you guys know? Huh? dip your head in ice. Have you ever tried to dip the head of your patient in ice?
Yes.
Well, it was not easy, huh? But it was not easy. You need to find the ice, you need to find the pocket, and the patient is in the ICU. Can you, sir, please just bring your head? It's not easy. So we rarely use that one. Another thing that you can do if your patient is unconscious, you can do a rectal exam. I had an old lady that actually went into complete AV block, and she coded because I was doing a rectal exam on her. So rectal exam is a good bag of money. Carotid sinus massage. When you do carotid sinus massage, remember the carotid valve is when the common carotid bifurcates into internal and external carotid. That's very high. That's close to the angle of the jaw. Okay? If you find your angle of the jaw and feel your pulse, you're close. If not, if you're not there, you're close to the bulb. Then the massage is not a Swedish massage. Okay? So what you want to do is pressure there. Okay? It's stretching. Okay? If it gets stretched, it's going to trigger. So you want to do firm pressure there. Firm pressure there. Okay? And be careful, no bruits, okay? And no contralateral issues. And then adenosine is another great tool. Okay? Adenosine use. Diagnostic and therapeutic. Okay? It's going to block my AV node. So if it blocked the AV node and I had a circuit there, it's going to block the tachycardia, I cure it. If it's blocking the AV node, so there, I don't have any more impulse going to the ventricle, I don't going to see any more QRSs. But if I have, for example, an atrial tachycardia or an atrial flutter, I'm going to see that atrial activity going on. That circuit's still going, or that autonomic focus is still firing. It's just not conducting to the ventricles, but I'm not touching it. And I'm going to see my baseline. Okay? That's why it's important always, always continuous recording. Ideally, if you have a 12 lead, hook your 12 lead, get the paper running, push your adenosine, make a diagnosis. We're going to see some examples. If you're in the VA and you're in an emergency situation and they tell you, you know, you need to go out and put the order in the computer, and then somebody that is in basement might come in 15 minutes for at least the telemetry, okay? But make sure that you have some report. The dose, 6 milligrams, start with 6 milligrams. The second dose, you can use 12 milligrams. Fast push. Again, it's metabolized in the endothelium. As soon as you push it in, it's being metabolized, and the red blood cells. So use an IV line that is close to the heart. If you have a central line, perfect. If you have a peripheral line, don't use it in the hand. As soon as you push it, when the times it reaches the heart, the dose is ridiculous. Okay? So at least antecubital. Okay? The closer to the heart that you can. Use a 3-way stopcock. Okay? So you can flush it fast. Hook your flush, hook your adenosine. Okay? And you can do it yourself or have somebody ready to turn the stopcock for you. And you push the adenosine and immediately push your flush so that reaches the heart quickly. Prevent the patients about what they're going to feel before pushing it. Okay? They're going to feel like they're dying. They're going to feel like they're having a heart attack. Okay? The heart is suddenly stopping. They feel chest pain, shortness of breath. Tell them, we're going to give you medication. It's going to make you feel funny. You're not having a heart attack. We're here with you. It's going to wear off quickly. Okay? And you're going to be fine. Have the pads on, ready to shock or pace. Okay, if you're going to do this, you have your card there, you have your patch placed into the patient. Sometimes they can go to a bradycardia, bad bradycardia. Okay, you have adenosine ready, you push your adenosine. If adenosine doesn't work, you're ready to pace. Vagal maneuvers of adenosine for diagnosis. What is the diagnosis here? Come on, guys. Been talking for about an hour and you guys cannot tell me what the diagnosis is here. Huh? Flutter. It's a flutter. So the K was a very fast, regular rhythm, narrow complex tachycardia. They didn't know what it was. Okay? They give him adenosine. It blocks the AV conduction, but the flutter continues in the atrium. Okay? And then after this, boom, it starts going back again. This one down here, SVT, poly-AV NRT. They give adenosine. It blocks the AV node, blocks the circuit, and this is a sinus peak here, followed by, preceded by a P wave. Okay? So this is the things that you can see with adenosine. Electrical cardioversion. Cardioversion is different than defibrillation. You're going to do defibrillation when your patient is fibrillating, ventricular fibrillation. Okay? The difference is the button that says sync. Okay? Checking the arrows. When you press the button that is sync, okay, don't do it without that. These arrows are going to come and mark the R waves. Okay? Now you know that you're syncing and the shock is going to be given in the R wave. The idea is you give a non-synchronized shock, it can land into the T wave, and RNT, and PNT is going to give you ventricular fibrillation. Okay, it's good because you're shocking, you just need to shock him again, but if you can avoid that, okay, you're going to live longer. Select your energy, okay, know your energies. If you're dealing with a supraventricular tachycardia, a flutter, low energies, 50, 100 biphasic. Atrial fibrillation, you need high energies. You can go to maximum energy. You got to go to 200 biphasic. If you're dealing with ventricular tachycardia, you don't want to lose time. You want to hit them hard. So the majority of the biphasic machines, they go to 200. For some reason, some of them, and I think at the VA, you have biphasic energy going to 360. Okay? So 200 biphasic is the same as 360 monophasic. 360 biphasic is more. Okay? But it's okay to use it. It's safe. Sedation, if they are awake, give them the sedation. If you don't have much time, at least give them the diversion. The diversion is they're going to feel it, it's going to hurt, okay? It's a mule kicking you in the chest, but at least you're not going to remember who pushed the button, okay? They're going to have the amnesia, okay? They're not going to remember that. So if you need to decide which give first, give the first first. Have atropine ready, and be ready to defibrillate. So this is the machine, get familiar with it, okay? You have the sync button, okay? After your sync button, you select your current. Your current, this one over here is the one for shocking. This one is for pacing. This one is for shocking. You select your energy, and you charge and you shock. This is the new devices that we have here. They have this door. If the door is closed, it's an AD. If you open it, it's a regular defibrillator. Your physicians, please open it. Don't use it like an AD. Okay. Same thing, same concept. The narcoleptic tachycardia, if they're stable and they're irregular, it's more likely AFib or multifocal atrial tachycardia. Look for the cause again and again and again. Rate control, calcium channel blockers, beta blocker, rhythm control, electrical or pharmacological. Okay, we're not going to go into those details. I don't want you guys to start pushing antiarrhythmics for this. We'll talk about it. We'll get it. The wide complex tachycardias, unstable, you shock. If they're in VFib, you're going to defibrillate. If you're there VTAC, monomorphic, you're going to cardiovert. Stable, pharmacological cardioversion. The two drugs that you need to know, okay, if you're going to use them, even for prevention after the patient coded, is these two. Amiodarone is a broad spectrum antiarrhythmic, okay? Long-term side effects, acute effects are rare, but they're severe. Lidocaine is the other one. Sometimes you see that lidocaine is added to amiodarone, kind of a desperate thing to do. But lidocaine is the best if this is in the setting of ischemia. If it's ischemia, you want to use lidocaine. Amiodarone, you give a bolus and a drip. The amp comes in 150. 150 is what you give if the patient is awake over 10 minutes. 300 is what you use in a code if you're pushing the chest. Lidocaine, you give a bolus. Remember 100. 100 bolus is fine, and then you start a drip. The drip is 1 to 4 milligrams. Electrical cardioversion, okay, you can do it even if they're stable. You just make them sleepy. Versed, fentanyl, shock them up. Look for underlying cause. This is important. Torsades, okay, long QT syndrome, post-dependent VTAC is a little bit of a different animal, okay. Usually people that have long QT, okay, you'll see a PVC, and then, okay, if you give amiodarone to these guys, they're going to do poor. They're going to do those methadone addict that is coming with torsades. They have a
very long QT syndrome, and they're having this. You give them amiodarone. The amiodarone is going to prolong the QT even more. Okay, it's going to slow the heart rate even more, and they're going to have more torsades. So that's why you sometimes will see somebody from the cardiology department saying, no amiodarone, stop that, and they will put the patient on something that increases the heart rate. They will put them on dopamine or isoproterenol, or they'll put a temporary pacemaker, okay? And you say, are you crazy? Are you giving dopamine to somebody that's just had VTAC and we shock them? And yes, if the mechanism, if I know what I'm treating, okay, I'm doing the right thing. So the example is this. You have a long QT patient, you have a PVC, and boom, okay, triggers torsades. Okay, this is another example. Okay, so these are the cases where amiodarone is not good. Okay, and we're going to use other tricks. You usually are going to have help, but have it in mind and know that what things are happening.
use all your tools. Patients have pacemakers and defibrillator. Somebody that is not you, tell me which one is the pacemaker and which one is the defibrillator. Yes. So these are the shocking calls. If you see shocking calls, it's a defibrillator. Okay. If you have no shocking calls, that's a pacemaker. And it can be used for treatment, but also for diagnosis. If you have an SVT and you don't know what it is, you have a cable in the atrium and you have a cable in the ventricle, and you can interrogate the device very quickly. In all the hospitals, we have the machines. There's always somebody that knows how to run the programmers. This is the programmer. Okay, you'll see them landing in the cath labs usually. And you run a diagnostic. Okay, and I see this is my ventricle, this is my atrium. I have a lot more A's than B's. Plenty of more A's than B's. This is not VTAC. Even this looks like a wide complex tachycardia. This is AFib with aberrancy. I make my diagnosis. So use your tools. If the patient has a dual chamber device, ask somebody to come interrogate it for you. Okay? Use all your tools. This is another example. Ventricular lead, atrial lead, more A than B's. This is a flutter. Okay? So it's very useful. Be a physician. Okay? Be a good internal medicine doctor. Don't treat the rhythm, treat the patient. Talk to your patient or family members. Always tell them what you're doing. Let your upper levels know of if you're pushing adenosine or doing any of these things. Okay? Training, you're being a physician under supervision. So be a physician, okay, but make sure that whoever is responsible for you is not getting in trouble. And be ready to answer any pertinent questions when you call for help. If you're calling somebody, say, hey, I need help, be ready to answer some basic questions. Just common sense. And this is just one last thing. This is my last slide. What you guys would like to do with this patient. So EP study, ICD, urgent CAS, or nothing. So basically, we're dealing with a ventricular tachycardia. Why nothing? Okay. So that's the right answer. But if the patient is awake and talking to you, okay? If the patient looks sick, okay, I'm not going to look for artifacts. So that's a very good pick, okay? You can march the QRS complexes, and sometimes we make that diagnosis. But make sure that the patient is talking to you and is not sick. This is another example of the same thing, how an artifact can fool you, okay? And we'll leave this for another talk. Any questions? Say that again? You won't use phenytoin. Let that for the cardiologist, okay? So we rarely use it, okay? We rarely use phenytoin. So the things that you need to know for torsades, you're going to give them magnesium, okay? You're going to look for the cause. You're going to get rid of the medication that is causing it, or the drugs are causing it. You're going to put the pads on, okay? You're not going to give amiodarone if you have a doubt, and you're going to ask for help, okay? So no phenytoin, don't use phenytoin. We didn't went through the criteria. The criteria, you guys will need to learn them, and they're a market list. But the idea was to clarify concepts, and whenever you read the criteria, it's not a memory thing, it's just understanding why they are there. If you guys have any questions about treatment, EKGs, feel free to contact me or any of the cardiology guys, okay? We are all buddies, so if you guys need help, don't hesitate, call us, we'll be happy to help. Any other questions? No? Okay.